Dear colleagues, as we unfortunately had to cancel this year's World Congress in Montreal, we thought it would be a good idea to at least share some highlights from the virtual Congress that took place in February. Before the video starts, I would like to announce that the 2022 World Congress in Taipei, Taiwan will take place from June 9th to the 12th. I look forward to seeing you there in person, and now please enjoy the video. Oh, and don't forget to subscribe to our YouTube channel below for free so you can watch more videos in the next weeks. Thank you.
Hello, my name is Jennifer Phillips. I'm joining you from Ottawa, Canada, and today I'm going to be presenting my research on the impact of intravenous ketamine on depression and suicidal ideation. There are two major unmet needs for the treatment of depression. First is the low response and remission rates among patients, and second is the delayed onset of antidepressant action that we commonly see with existing treatment strategies. Over the past decade, it's become clear that ketamine is showing real promise in addressing these major unmet needs. In our research group, we've largely been focused on trying to figure out how to best use this medication clinically and how to extend its benefits over the longer term. Our focus has recently shifted to also determining how or whether we can predict who will respond to treatment, as well as uncovering mechanisms underlying ketamine's antidepressant effects. Today, I'm going to be presenting our clinical findings from a trial looking at single, repeated, and maintenance infusions, as well as our first biomarker data exploring inflammation and its relationship to treatment-resistant depression and ketamine treatment. Results I'll present are ketamine's effects on depressive symptoms. This is the results of the random linear mixed model, which random effects linear mixed model with MADRS scores here on the y-axis, as they changed after the single infusion from pre-infusion to 2 hours, 24 hours, and 7 days post-infusion. And here we see a significantly larger decrease in depressive symptoms with ketamine compared to midazolam. And at our primary efficacy endpoint of 24 hours post-infusion, patients had an 11-point drop with ketamine compared to only a 3-point drop with midazolam. So overall, this was significant, but only 27% of patients achieved response with that single infusion. Because of ketamine's transient effects, there has been a move to administer repeated infusions. This is the results of our repeated infusions phase, or phase 2 of the trial. And you can see a dramatic difference between patients who achieved an antidepressant response compared to those who failed to respond to the treatment over time. And in fact, we had a doubling of the antidepressant response rate compared to single infusions. We found 58% of patients responded to the repeated infusions, and over time they showed a cumulative decrease in their depressive symptoms with each infusion they received over phase 3. Overall, there was a 22-point drop in MADRS scores on average in the responder group, and they ended the end of the repeated infusions just above 10. So these individuals then entered immediately into phase 3, the maintenance phase, where they were administered 4 once-weekly infusions. And clearly you can see there was no further change in their depressive symptoms, indicating a potential maintenance strategy, which can allow for the reduction in the frequency of infusions, but maintenance of the antidepressant effects in patients who achieve a response to more frequent medication. So to date, there's significant evidence accumulating that ketamine is effective for depressive symptoms as well as suicidal ideation. And we've seen that it can have higher response rates compared to other treatments for depression. But as I've shown, not everyone responds to treatment. So a move in the field has begun to look at biomarkers that might help us identify individuals who are likely to respond to this treatment. As well, the biomarkers can help uncover underlying mechanisms that are driving these antidepressant effects. So in our clinical trial, we not only looked at clinical outcomes, we also collected a whole series of biomarkers from blood and saliva samples, EEG, actigraphy, cognitive testing. Today, I'm going to focus on our inflammation findings. And these are from blood samples collected prior to treatment initiation at baseline, at the end of the repeated infusion phase, and at the end of the maintenance phase for responders. Animal studies have shown that the effects of ketamine on depression may be driven by reduction in inflammation. We decided to look at plasma C-reactive protein, or CRP. This is a widely available clinical tool, and plasma CRP is present in the periphery and is elevated in the presence of inflammation. So individuals will receive value for their CRP levels, and between 0 and 3 is considered low or moderate, and anything above 3 milligrams per liter is considered elevated. This is associated with an increased risk of cardiovascular disease. And depression, especially treatment-resistant depression, has been shown to be associated with elevated CRP in the periphery. So this is the measure that we used in our sample using an ELISA to evaluate CRP levels throughout the trial. Here I'm showing the distribution of individuals who had low or moderate CRP and those with the elevated CRP of above 3 in the trial. You can see that nearly 50% of our sample had elevated CRP at baseline, and we found no sex differences in CRP at baseline. In summary, ketamine rapidly decreases depressive symptoms and suicidal ideation, with repeated infusions able to sustain the beneficial effects. There's a significant relationship between peripheral inflammation and the severity of clinical symptoms at treatment initiation. And we saw no change in CRP levels with repeated ketamine infusions. So there's a need to examine alternate biomarkers and more biomarkers in ongoing trials, which is something we're doing in our work.
Hi, I'm Steve Levine. It's a pleasure to be here virtually. Thank you to Pierre Blier for organizing this symposium and for including my talk, which focuses on the real-world use of ketamine in clinical practice. Just as a recap, I mentioned that we had presented some of this data, 740 patients worth from mid-2014 through the end of 2016 at the 2017 thematic meeting. I won't go through this whole poster now, and of course, the poster is much too small here for you to read, but some of the highlights were that, again, this was 740 patients representing about 7,000 infusions across the 7 locations that existed at that point. And some of the interesting numbers were the average dose delivered was approximately 0.6 milligrams per kilogram. This was longitudinal data. And on average, we saw that a given patient had just over 9 infusions. This data demonstrated fairly durable effect for these patients with a mean interval between maintenance infusions of just over 4 weeks and demonstrating an overall 75% response rate, including both partial and full responders. We were primarily treating patients with a primary diagnosis of depression, and at that, primarily severe depression. So almost 71% of patients had a ICD-10 diagnosis of severe and recurrent major depressive disorder, including moderate depression. That's now over 80% of these patients. 11% had a primary diagnosis of bipolar depression, and just over 3% had a primary diagnosis of PTSD. Almost every single patient was severely treatment resistant. So these are, by and large, severely depressed, treatment resistant depression patients. And as we might expect with that population, comorbidities are the rule, and these were primarily anxiety disorders. Generalized anxiety disorder, panic disorder, social phobia, representing the bulk of these comorbidities. Also almost 30% of patients with PTSD. And then a significant grouping also with OCD, dysthymia, and ADHD. So looking at the outcomes, as I mentioned, the timing that we're looking at here is the point just prior to a patient receiving their first maintenance infusion. And the cutoffs we're looking at are a less than 25% response, who are our non-responders, partial responders who had at least a 25% reduction in their symptoms, responders with at least a 50% reduction in symptoms, and then those who met remission based on the cutoffs on the QIDS-SR-16 and GAD-7 scales. We included a breakout of at least a 25% symptom reduction as partial responders, because by and large, these are patients who would say that they correspondingly noticed a meaningful improvement in their quality of life and therefore felt they were benefiting from treatment and would want to continue. And so looking at depressive symptoms, we have over 35% of patients who at this point would be considered non-responders, 64.5% who are the partial responders, 41.2% who met that response criteria of at least a 50% reduction in symptoms, and 18.2% in remission. And then on our anxiety scale, on the GAD-7, about 38% non-response, 62% partial responders, 42% response, and 20% in remission. And an important note here, this response breakout is of 1,033 patients. Why not the full 2,256? Because they did not have complete records. We were missing scales at some point. We were missing other important data points. And so these are patients who not only had a first maintenance infusion, but were deemed to have a complete data set. Unfortunately, this is a reality of real-world evidence, looking at EHR data, and with data that wasn't necessarily collected in the first place in the interest of conducting research so much as providing clinical care. So that is certainly a limitation of this data set. And again, as a reminder, when we look at these response rates, this probably is not fully reflective of the course of these patients over time, given that the scales were administered prior to this infusion, and on the whole, these patients were having some relapse of symptoms, which is what brought them into treatment on this day. So that brings us to our conclusion. This does represent the largest known single data set of patients receiving IV ketamine for psychiatric indications. Certainly acknowledge the limitations of this data, both in terms of the timing of administering the scales, as well as the completeness of the data for many of our patients, really limiting the number of patients we could look at in a meaningful way. But despite that, gratified that our patients had overall a meaningful reduction in their depressive and anxious symptoms within this quite severely ill and treatment-resistant population. But certainly future data collection is intended to be improved with a digital platform that will standardize the timing of measurement and also improve adherence to the method of collecting the data.